All right, welcome back to Pharm 2. It's a lot more of the same. Just to kind of go over the course real quick. So everyone was able to get the first set of PowerPoints downloaded. You can see everything. The sticky board is still there, so I'll still check that periodically. It breaks and at the end and whatnot. There's going to be 4 sections to this course. So there'll be 4 exams and also 4 prescription assignments. So you'll see those there. The thing I'm switching up a little bit this time around is we're getting more into sort of like inpatient orders rather than just doing strictly outpatient prescriptions. So to give you an example what that'll look like, and you can see the actual assignment you have up already, but here's an example of some inpatient orders that you're writing for a fictitious patient. And you notice here it's a little different in terms of like kind of what's required, what's not required here. The biggest thing to note is just to make sure your orders are complete. So for instance, if you say something is every 2 hours PRN, you have to say, well, PRN what, right? So for instance, if you're saying I'm giving Zofran Q8 hours PRN, some of you might know you would say nausea and vomiting, right? So you can say that. You could say for pain. You could say whatever you want to do for if it's appropriate for that drug itself. So make sure you have your route that's going to be there, your dosing, the frequency. Now you know here there's no information about refills because refills don't really pertain to inpatient orders. There's nothing about dispensed quantities. You don't have to worry about that, right? You just want to make sure you're writing specifically what you want that patient to get, and then who handles that from there. Usually comes to us in the pharmacy department. We'll process the order, and then your nurses will get a hold of it, and they'll get the drug and actually give it to the patient themselves, right? So this is why you want to have information for things like, hey, do you want that IV push, or do you want it to give over a certain period of time, right? When I say IV push, how long does it take to get that med into the patient? However long it takes a nurse to kind of push it in, right? Usually it's like 30 seconds to a minute. Some people just really slam it in there even faster than that, which is appropriate in some cases, like adenosine. We talked about how that has such a short half-life. You really have to get that one in quite quickly. But other medications may not be so appropriate, right? So for instance, with vancomycin, what was the problem with giving that drug too quickly? Yeah, remember Red Man syndrome, right? Person would say toxicity. Yes, of course, toxicity, being very vague, but more specifically, it's that Red Man syndrome we're talking about. So that's why we give it over 2 hours, for instance, right? So, and you'll find that information if you're looking in Lexicomp. If you go down to the administration section, we'll tell you about roughly how long things can go over, right? So that'll be another important thing you want to look up there. So you'll check out the prescription assignment. If you have any questions, let me know, and we'll go through there. That'll be due the Friday before your first exam here. So don't let that surprise you. It's all up there. Again, if you have questions, let me know. In terms of how the course is going to be organized by the actual topics, it was kind of tough because you have a lot of CMS, different stuff going on all at the same time. So I kind of organize it based off of your testing schedule. So I think Neuro is probably the first exam you have. So I'm covering Neuro first, right? So hopefully it'll line up well enough for you. It may not be perfect, but that's kind of the nature of the beast as it turns out. And again, if you're looking at the actual syllabus, wherever that is, you can see how the grade's broken down. So 80% will be all of the exams. Again, no cumulative exams or anything like that. 20% is going to be just the 4 prescription assignments. Okay, does that make sense? Kind of like last semester, just a little bit more stuff. Any questions on how the course is going to go? Anything at all? Anyone have any interesting drug stories or anything over the break? Nothing at all. Hopefully not too many drugs were taken, unless they were prescribed to you by a provider. But anyway, and I was, and I read the reviews from you guys, and I really appreciate how candid you were for a lot of them. Turns out EpiBio is everyone's favorite class ever. I was really surprised by that, so I'm going to try to make this class more like that one. So just, not kidding. That class is always kind of a beast because you can't really do a whole lot with it. It's pretty dry, but hopefully it'll make more sense in the summertime when we get to pub skills. Like all that stuff you learned back then will make a lot more sense in terms of like actually going through the literature and whatnot. Anything other than that before I get started? Any thoughts? I'm probably thinking of something else as I go along. But anyway, let's get going here. So we have our neurology section we're going to cover first. You can kind of tell this topic is going to be a bit of a big one if you look at the number of slides. Just a couple, just a few. Anyway, let's talk about epilepsy first. What have you covered with Professor Kaplan so far? You had 2 hours. I can't imagine you covered nothing. Okay. I didn't know if he was like ranting about his thoughts on Rise of Skywalker and The Mandalorian, or what. I could probably go on for 2 hours about that myself, but we're not going to do that today. So, so in terms of epilepsy, what is a seizure? What is that? Abnormal brain activity, abnormal neuronal firing. I kind of think about it just like an arrhythmia is an electrical problem with the heart. I think about a seizure being an electrical problem with the brain, right? And we'll see that a lot of that's going to be pretty consistent in terms of like action potentials and talking about refractory periods and all that sorts of thing. And in fact, if you recall our antiarrhythmic drugs, remember what was the class 1 antiarrhythmics? What was their main mechanism? Sodium channel blockade. Well, guess what a lot of anti-epileptic drugs do as well? They block sodium channels. And in fact, one of the big ones we'll talk about here is called phenytoin. Phenytoin originally got its start as an antiarrhythmic drug, and they realized it didn't really work all that well for that, but it worked a lot better for seizures. And so that's where you can see some crossover between those, and it'll kind of make sense, that blocking sodium channels affects phase 0 depolarization. Same thing happens here in the brain, just like it does in the heart itself. And so when we say epilepsy, it's kind of that collection of different seizure types that a patient may experience, whether they're partial or generalized and all that. We'll cover some of that. I'm not going to go into great depth on the different types of seizures. There may be a few examples where certain drugs are better suited to treating certain types of seizures than others. We'll talk about those. And then when I say status epilepticus, what does that mean? Kind of continued seizures, or basically you can have multiple seizures in a row where patients don't kind of get back to their baseline mental status. What do you call that period where someone just has a seizure and they come back and they're kind of out of it, still kind of sedated? Post-ictal, right? So they're still in that post-ictal phase and they go back into a seizure. So that's what status epilepticus is in those cases there. We'll talk about ways we can actually go about treating that as we'll see in a little bit. So why do people have seizures? What are some common reasons? Anyone know? Yep, absolutely. So we'll talk a lot about med-induced seizures. Talk about those. Anything else? Fever, yeah. So you can have like febrile seizures. They're treated. You see that a lot in infants, right? Anything else? I have a whole list of them on the slide. But things like head trauma can induce this. You can just have bad genes. You could have actual structural abnormalities. We have a lot of kids who have a hypoxic event very early on usually in their infant life, and then that leads them to have ischemic injury, which leads to seizures later on. We see a lot of kids like that. CNS infections, sometimes meningitis can present with a new onset seizure. A lot of different things here that can usually have one of those seizures. We'll talk about medication use as well, and there's a lot of different drugs here, and a lot of these we'll talk about when we get into the behavioral health section coming up a little bit later in this class. But some of these drugs may not necessarily be the presence of them that causes the seizures, but it may be the withdrawal thereof. So for instance, alcohol, is that normally a stimulatory or a sort of depressive sort of med? It's usually depressive, right? People usually get more sedate. Usually does not cause seizures, and in fact can actually treat a seizure potentially. We'll look at the mechanism a little bit later. But when you have alcohol withdrawal, that's where you can end up developing things like withdrawal seizures. You can develop, anyone know what you call the 2 letters you call when someone's withdrawing from alcohol? The DTs, what does that stand for? Delirium tremens, yes. So that is a very severe form of alcohol withdrawal that usually will have things like seizures presenting there. But a lot of other medications, we'll talk about those. Another important thing to note as well is that just like with antiarrhythmics, not only do they treat arrhythmias, but they can also cause arrhythmias. Anti-epileptic meds can also cause epilepsy in and of themselves. And a lot of them do have a narrow therapeutic index, which means sometimes we have to do drug level monitoring for a lot of them to make sure that the levels are getting high enough to where they're going to be effective for their seizures, but they're not so high that they're going to cause a lot of toxicity, which in a lot of cases may be a lot of sedation, maybe memory impairment, maybe a lot of things like that, but could lead up to seizures in some cases there, right? So when I say AEDs, that stands for anti-epileptic drugs in this case here, okay? But also think about things like patients coming in with a seizure history and they're coming in with new onset seizures, or not new onset, but a new episode of seizures. You have to think about things like non-compliance, right? So if they were taking a medication for their seizures and then all of a sudden they stop taking it, that can precipitate a seizure, right? And patients may not be forthright with you when they're coming in, right? So that's why sometimes we'll actually do levels of medications to even see if the patient's actually taking it like they're supposed to. So we'll talk about some of those different things as we go forward there. Again, we'll get into the antipsychotics and the antidepressants later on in this section here, or in this course, so kind of keep in tune for that. Even things like hormonal changes, even things like sometimes puberty can be a trigger for seizures to start occurring as levels of testosterone and estrogen, things like that start to change. But essentially what we're going to find is that we're having this abnormal firing of the neurons. Usually they have this hyperexcitability, meaning that they're just a little too sensitive. They're very likely to send off an action potential. And normally you'll kind of lose that organized sort of electrical impulse system there. And just like with the myocytes, we saw that they have a refractory period. You'll see that the neurons also have a refractory period as well. And refractory period just means what? Period of time where it's kind of in a phase where it cannot be re-triggered again. Usually it's kind of like the resting state until you kind of repolarize it and get back down to that resting membrane potential, and then it can be ready for a new action potential to come along here. We're going to talk a lot about different neurotransmitters in this course this semester, especially when you get to behavioral medicine, talk all about dopamine and serotonin and all that good stuff here. The two primary neurotransmitters we're going to talk about are going to be GABA, and then it's going to be glutamate is going to be the other one. Okay, so what does GABA do for us? It's inhibitory, right? So if you think about your brain as a car, GABA is going to be the brakes on that car, right? So if I activate GABA channels, it's going to slow everything down, right? How does that work? Why does it cause the neurons to slow down? Because it influxes certain ions, and you know what the ion is? Chloride, right? We're going to find that when you open up GABA channels, it's going to cause chloride to flow in. And what does that do to the resting membrane potential? That neuron. It's going to lower it. It's going to make it even more negative, which makes it more difficult to have an action potential, right? So I can either let the positives out to make it more negative, or I can allow more negatives to come in. Okay, so kind of the two balances there. So find GABA is our major inhibitory neurotransmitter. Glutamate is going to be the major excitatory neurotransmitter, right? See, there's a lot of different types of glutamate receptors out there. Some of them allow for things like calcium influx to occur, which is going to be excitatory. Some of them are directly stimulatory. We'll find a lot of different purposes there as we go along. Now, what's actually interesting is that there's a nice kind of balance between glutamate and GABA, because how do you make GABA? Well, you actually make it from glutamate. There's actually some substances where it will inhibit that process. If you inhibit GABA formation, what do you think is the primary way those patients will present? If I got rid of all the GABA, they present with seizures, right? Because they have way too much glutamate, they have way too much excitatory sort of activity there, and that can predispose them to seizures. Of course, I'll go off on tangents all semester, just like last one. But there's certain types of mushrooms actually that if you ingest them, called gyrometrin-containing mushrooms, they have a compound in them called hydrazine, and hydrazines actually prevent that conversion from glutamate over to GABA, and so they'll actually will present with seizures as their main thing. And you can give them all the medications you want in the world, but because they don't have any GABA around, it's just not going to work for them. You actually have to give them pyridoxine. Pyridoxine is actually the antidote to that, but not that it's going to be on the test, but just a little interesting thing. Also, don't eat mushrooms that you find growing out there in the world. Anyway, so we're going to find that there's a balance there between GABA and glutamate. Too much glutamate, you see seizures. Too much GABA, what do you think that would look like? Sedation, right? It'd be maybe syncopal episodes. You can find, you see respiratory depression in some cases, so it's kind of global depression that you're going to be seeing with GABA. Now remember, the action potentials here and the normal kind of electrophysiology of the neurons are very similar to a lot of the myocytes we talked about, right? So what's responsible for maintaining that resting membrane potential in the neurons? Sodium, potassium, ATPase pump, right? So, and in fact, when you looked at a drug that inhibited that pump, what drug was that? Digoxin actually was a drug that inhibited that sodium, potassium, ATPase pump. What is one of the side effects you saw if you had too much? Well, mental status changes, right? And that makes sense because it can affect your neurons as well. And so that sodium potassium pump is really important for maintaining that electric potential. If that is altered at all, that can either lead you to having hyperexcitable neurons or maybe less excitable neurons, depending on the situation there. And again, looking at that refractory period, the longer that's going to be, the longer it's going to take before that neuron's ready to fire again. That's going to be helpful to stopping those seizures from occurring. And that's mostly going to be done by trying to make sure they're as negative as possible, and usually by helping to get as much chloride into that cell as you can there. Okay. And one of the terms we'll use as we're talking through this is called the seizure threshold. It's kind of hard to say, try to say it 5 times fast. But the seizure threshold is something that we'll talk about how certain things can either raise it or lower it. So if I were to say we're to lower the seizure threshold, what do you think it means for your patient? You're more likely to have a seizure. If I were to raise it, that means they're less likely to have one. That threshold's higher, it's harder to meet that criteria. And so, for instance, certain drugs will lower the seizure threshold and make it more likely your patient's going to have a seizure, right? So one thing we'll kind of talk about as we go through. So anyways, when you're diagnosing your patient with a seizure, again, I'm not going to get in depth on the diagnosis because that's what CMS is for, but some of the things I just want you to kind of make note of when you're getting your history out of your patients here is, one, ask them, have they ever had a seizure before, right? Sometimes that can be an important thing where they may have had a sort of a reversible risk factor that caused them to have that seizure in the first place. Maybe it's come back now, right? List what medications are going to be on, right? Some of these medications may be causing them, maybe withdrawal of certain medications may be causing seizures. You want to get a good, accurate history on that one. And of course, between seizures, you're not really going to find any real physical exam findings, right? Once they're out of that post-ictal state and they're back to their baseline mental status, you really shouldn't really find much there. And that's why different laboratory testing and diagnostics can be really useful here. So things like EEGs, MRIs, etc. Now, in terms of like labs and toxicology screening, this is where it can be really important to know what medications the patient's on. So you can do levels, if levels are available, or you can do maybe a toxicology screen to see if something is present in the urine that may be predisposing them to a seizure, right? Anyone know what kind of stuff shows up on a tox screen typically? It can be variable depending on where you're working at, but there's kind of a general 7 items that will come up on the grand majority of them. So you have things like cocaine, amphetamines, PCP, any other stabs, what else might be on there? THC will be on there, anything else? LSD, not that one specifically, it's more of a specialty lab. But you can see things like, what else did I miss? Heroin, like opioids are going to be on there. Benzodiazepines are also going to be on that list as well. We'll talk a lot about benzos in this section here. So some of those things can definitely predispose you to having seizures. So for instance, if someone came in and they had a history, had a witness seizure, and they test positive for amphetamines, you may lead you down that road to say, okay, well maybe amphetamines are leading to the seizure here because we know it's a stimulant sort of drug. Again, not going to be foolproof. There's a lot of reasons why patients have seizures, and a laboratory value may not be the only way to actually diagnose that. But here's just a little ancillary slide, just for your edification here. Us people in tox, we always like our acronyms. And this is the way we remember a lot of toxin-induced seizures. The main takeaway from this, our acronym of Otis Campbell. Again, it's not catchy, but it's how we remember it. What do you notice about this list? How about the length of the list? Quite long, it's quite extensive. There's a gazillion things that's going to cause seizures, right? So it's really hard to try to look and see, like, okay, well, why is this patient having this? Some of the things to note, though, right? So for instance, if your patient's having a seizure because they're hypoxic, there are quick things you can do to try to fix that, right? So, okay, we can find if they're hypoxic, give them oxygen, boom, they're fixed, right? If they come in seizing because their blood sugar is 35, we can give them sugar, right? So you guys ever heard of a coma cocktail before? So that's something where if you had a patient who presented with altered mental status, right? Maybe they're altered because they're post-ictal, you don't even know if they had a seizure or not. Those are kind of common things you can give to try to reverse to see, okay, well, is there any easy identifiable cause why that patient is having an altered mental status? So you give them glucose, you give them oxygen, and give them naloxone. Anyone know what naloxone is? Narcan's a brand name. What is that used for? Reverse opioid overdose, right? So if a patient's altered because of opioids, could be a thing you can give them to easily find out that's one of the causes there. And so you can give those drugs to the patients to see, okay, does that fix their mental status? But a lot of things on here can definitely cause seizures. Again, remember, withdrawal of certain medications can also do that, like ethanol withdrawal, benzodiazepine withdrawal, all of that can lead to withdrawal. And again, that's where things like having a good medication history can be really helpful with that, right? Okay. So what are our goals? Ideally, we'd like to have patients have no seizure, but seizures are kind of tough too because they can be kind of intermittent, and it could be tough to say, like, well, are the medications working? Are they preventing seizures, or would the patient just not have had seizure in the first place, right? So it can be difficult to tell. However, they're definitely going to have side effects from the medications in a lot of cases there. So it's one of those things of balance where you're saying, like, well, how efficacious is this medication being if they're not having any seizures at all? You guys ever heard of like elephant spray? It's an analogy. It's like, look at this elephant spray. It's working really, really well. Look, there are no elephants around. Well, yeah, there wouldn't be any elephants right here in the first place, right? So it's one of those things where you don't know if the medication is really working or not, but you want to look to at least see, hey, they're not having any breakthrough seizures. I'd like to see they have no side effects. And obviously, you're looking at things like their quality of life, what kind of changes are these medications causing the patient, see if you can deal with that. Now, do you think every patient can meet all these criteria? No, sometimes you're just looking to see, can we get just a reduction in the number of seizures patients are having? Some patients are coming with dozens of seizures in a week or in a day. Just getting that down, any significant percentage could be really helpful in terms of quality of life. So again, not going to be perfect for everyone, but we try to do the best we can. So some of the things we're going to consider when evaluating patients, getting them started on anti-epileptic medications here. Note their age. Age is really important. We'll talk a lot about pediatric pharmacokinetics later on in this class. We talked about that a little bit in pharmacodynamics, if you guys recall that or have not suppressed that memory yet. But you can see here in terms of their kinetics, it can change pretty significantly based on the age of the patient. So I mentioned phenytoin is a common anti-epileptic drug we'll talk about. And you can see here the dosing actually changes based on the age of the patient there. So what do you think is happening in this case here? Notice that they require more medication early on, and that dose starts to dip down as they get older. Why is that? Has to do with things like maturation of the liver, has to do with things like enzyme expression, etc. You'll notice as well that not only are these patients getting older and their actual handling of the drug changes, but also what changes a lot in kids as they get older. Their weight's going to go up too, right? So you have to also consider that. And again, the medication may be really good. They may be on a really good dose for them for a while, and then all of a sudden they start to have breakthrough seizures. You need to go back through and reevaluate that dose, make sure it's still appropriate for that patient, right? So kinetics can be a really important thing. You'll find all this stuff in LexiComp if you go, or whatever drug reference you're using, to see specifically in pediatrics, how are they going to process this. Look at other medical conditions that may be predisposing to seizures or maybe interfering with their medications potentially. And then again, how are they going to actually be able to comply with the medical regimen? You can give them 3 or 4 drug cocktail, but if they can't afford the medications, then it's not really going to do a whole lot of good for them, right? So insurance coverage is really important. Make sure that they can actually get the medications that you're prescribing to make sure that they're going to be compliant. Okay, so first off, we want to figure out, did a seizure actually occur? Now, is there ever a case where people will have what we call pseudo seizures? Why would that happen? Attention, maybe. What other reason? Yeah, if I come in with a seizure to the ER, I'm having a believable seizure, they might give me medication for that. Things like benzodiazepines make you feel pretty good. So in some cases it could be drug-seeking behavior. Sometimes it's just malingering. It could be a lot of different reasons for that. We have some patients who are in the ER. Remember this trick we used to do? We'd have a patient who is quote-unquote post-ictal, and so we did this hand test where basically they were laying back on the bed and we lift their hand over their head and we let go. And presumably if they were actually unconscious, what would their hand do? Smack them in the face. Guess what this patient did? Pulled it away. Oh, interesting. They still maintain that reflex even though they're unconscious, according to them, right? So, again, not to make you cynical or jaded early on, but patients may not always be truthful with you, right? That's the thing. So if it did occur, what type of seizure was it, right? So for instance, if you're having an infant coming in and their temperature is 103 and they had a seizure, well, it's probably going to be a febrile seizure. It gets treated differently than a typical seizure of non-febrile causes, right? You want to figure out, is pharmacotherapy actually going to be indicated here? Do you always want to start with the first seizure? Maybe, maybe not. If it was a reversible cause, they may not need medications for that, right? Generally, yes, so if they have 2 or more sort of unprovoked seizures, there's no obvious reversible causes, yeah, you want to go ahead and start pharmacotherapy at that point. And then the question is, well, what drug is most appropriate? How are you going to monitor for that stuff? We're going to talk about that as we get into the individual examples here. So what are our treatment options? There are several. Pharmacotherapy is probably going to be kind of the mainstay for most cases here of seizures. You're going to find that a lot of patients they are well controlled on just one anti-epileptic drug. Some patients may need 3, 4, 5 drugs in some cases. It can get pretty extensive, and the drug interactions are no joke. Right? You have to look to see which ones are inhibiting metabolism of another one, and that one's inducing metabolism of another one. It can get very tough to deal with when you have these really complicated kids here. Other things you can do though, things like vagal nerve stimulators, sometimes actually taking out a portion of the brain that may be actually causing the seizures is possible, right? It's in some rare cases. And there's things like ketogenic diets. What does that do for us? So a ketogenic diet just means what? Right, low to no carbohydrates, right? That puts you in a state of ketosis where you're metabolizing fatty acids for energy rather than using carbohydrates. And what does that do to, say, for instance, like your pH? Yeah, right, ketoacidosis is a thing, right? So it actually lowers your pH. Having a lower pH actually makes it more difficult for those neurons to fire, so it actually helps to increase that seizure threshold. So some kids are on a ketogenic diet, and that's actually a really important consideration, especially like in children. Right? We get those kids coming in all the time, and actually if you're ever like working at a pediatric institution and they have an allergy to dextrose, you think, well, that's crazy. Why would you can't have an allergy to dextrose? You wouldn't be able to live, right? But actually what it is a kind of a warning sign to all the practitioners that, hey, this patient is probably on a ketogenic diet. You have to be really careful because in general, can little kids take tablets? for the medications? No. Oftentimes you have to use suspensions and syrups and things like that. What's a big component to a lot of those liquid medications? Sugar, right? So again, just by giving them a liquid medication that has a lot of sugar in it, you can screw up their whole ketogenic diet, knock them out of ketosis, and guess what? Now they have a seizure, right? So these are really important considerations here. We have to do things like take tablets and then crush and suspend them in water instead. So that helps to get rid of all that sugar content. Dietary needs to know about that. Nursing needs to know about that. Pharmacy, everyone needs to be aware of that. Otherwise, you can really screw that patient up and then get them having a seizure when they wouldn't have had one otherwise, right? So again, how do you determine the optimal seizure therapy or anti-epileptic therapy? Again, look at things like drug interactions, the goals. Are you just trying to eliminate all seizures or just get them down to a more manageable number? We're going to look at things like mechanisms of actions. Now, typically, you want to make sure that if I had the choice of using 2 medications with the same mechanism or 2 medications with different mechanisms, where would I get more bang for my buck? Different mechanisms, right? So you have to look at that and say, okay, well, I can use these 2 medications together. Does that make sense, right? Do they have the same mechanism? Just like we were talking about with, like, say, antiarrhythmics, you wouldn't want to use 2 sodium channel blockers together. Similarly here, you're going to find you want to use things with complementary mechanisms that can help one another out, okay? Look at our goals, compliance, and cost. We'll kind of cover those things as they come up with the individual substances. Okay, so again, generally you're going to start off with monotherapy for these patients here. So again, they're going to have, in some cases, similar to something like asthma, right, where you had controller medications that were on board 24 hours a day, and then you had rescue medications that would be used if you were to have an actual episode. Similar things can happen here with patients with seizure disorders, where they'll be on kind of controller medication throughout the day, and then we have as-needed medications in order if they have an acute seizure. And so if you ever see patients with like something called Diastat or diazepam rectal gel, that's a common one. We'll talk about some other examples there a little bit later. It's kind of a rescue sort of medication. And then basically once you start off with that single drug, see how they're doing with it, see how the side effects are affecting them, see how what their seizure history is like after that, as you start that up, and then you may need to add on additional meds if need be, right? In some cases, they have a particular type of seizure disorder or a particular type of seizure. Their individual drugs are actually indicated for that. So I don't talk about it here so much, but there's a brand new one called Epidiolex. Anyone ever heard of Epidiolex? You know what it is?
I only saw it a few times when I was doing EEGs, but it was with one patient I can't remember.
Yeah, so actually it's CBD, right? Anyone know what CBD stands for? Cannabidiol, right? So if you look at the marijuana plant, you have THC as the main psychoactive compound. CBD or cannabidiol is actually the other big component thereof, and is really useful for things like neurologic conditions. And in fact, there's one FDA-approved cannabis product, and it is this cannabidiol product called Epidiolex, and it's actually only indicated for 2 exact specific types of seizure disorders. There's Lennox-Gastaut, I believe it's called, and then there's Dravet syndrome. Those are like just 2 very particular type of seizure types that's approved for. And so, again, just goes to show you that it can get very specific in some of these cases here. We'll talk about most of them here as being kind of more general and being able to use for many different types of seizures, okay? Actually, I had one of the, you guys ever heard of an MSL before? So, you know, like, there's drug companies, and they have like the drug reps who are typically not healthcare providers. They can kind of go out and they kind of say, hey, why don't you come to this dinner? Or here's, you know, here's this great new drug, blah, blah, blah. There's an MSL, which is a medical science liaison. Those are typically healthcare providers, either like PAs or docs or pharmacists or whoever, and they're actually more specialized in actually talking about the medications, going through studies and things like that. I had a lady who came from Epidiolex, who was talking to a group of students I had. It was really kind of interesting because they actually have a specific plant or a greenhouse they have over in Europe where they grow the actual marijuana, and they have a specialized kind of extraction process they use. And they're like, yeah, you know, we used to use the greenhouse for before it was used for marijuana. I said, what? And they said tomatoes. And I was like, oh, that's really kind of funny. You can look up that connection there a little bit later. But anywho, so getting into, we'll talk about specific medications. Again, most ones we're going to talk about kind of general purpose. We'll talk about how they're going to use there. And again, many times once they've failed multiple drugs, that's when you're going to add on things like, you know, ketogenic diets and things like that. Okay, in general, you want to start low and go slow with these medications because the side effects are definitely going to be felt by the patients. They may not necessarily know how efficacious it is because, again, depends on how often they would have had seizures in the first place. And so titration time is going to be very patient dependent, depending on how they're actually responding to the medication itself. Again, you may need that therapeutic drug monitoring, so one, it can help you to determine if they're being compliant with their medications, or it can actually help you out to make sure they're in that nice narrow range where they're going to be getting efficacious effects from the drugs while also trying to mitigate some of those toxicities there. I'm not going to have you memorize all of the actual drug levels, but I will put maybe like a drug level on a test question, put the reference range, and say, hey, how do you interpret this? What do you want to do with this medication order here, right? And then you can adjust the dose based off those drug levels potentially. And again, based off of treatment failure or adverse effects that may require you to end up switching over to a different type of medication altogether, either a different mechanism or maybe one with a similar mechanism that maybe has a little bit more favorable sort of profile there, okay? Keep in mind though that anytime you have the withdrawal of that medication, you want to cover them with something because otherwise it could have that withdrawal seizures from that medication. Okay, and so in general, this is kind of the flow diagram you'd end up going through, the flow chart you kind of use to determine how efficacious and what you should do if it's not working there, right? So you diagnose the patient, you begin with one anti-epileptic drug or anti-seizure drug, it's ASD in that chart there, and then again you're going to see, are they seizure free, right? So assuming yes they are, then you got to figure out, well, how are the side effects, right? Are they intolerable? Then you may need to end up switching over to something else, either change the dose or maybe changing medications entirely, right? And then kind of going through until you can find kind of a nice happy medium where the patient is good with the side effects, good with efficacious, or how efficacious the drug are, and then you're good to go, right? On the other hand, though, if they're having intolerable side effects or they're not seizure-free, then that's where you have to either consider adding on another medication or maybe switching classes entirely, right? So we'll talk about some different drugs as we get into the specifics here in just a little bit. And you just kind of keep going back through the process again, seeing how they're responding to it, and then either altering your dose, changing the drug, maybe adding on a drug, whatever you need to do to get them the meeting the goals that you've kind of agreed upon with the patient. Okay, so looking at the main targets. Oh, yes, ma'am.
Why would you stop after 2 years?
So for some patients, if they have, it depends on the case, all right? So in some patients, they've been on for 2 years, they've been seizure-free that whole time. There is a chance that maybe they'll be able to wean off of that and see how they do, right? Some people may outgrow their seizure disorder. A lot of patients don't, right? Depending on what the issue is, right? If it's more of a structural sort of issue, maybe due to ischemic injury, that's not going to really correct itself, right? Versus maybe it was related to hormone levels or maybe it was related to stress or something like that, then that may be a candidate for them to withdraw off of that, right? Because again, you'd like them to not be on any medications, but a lot of them are going to be lifelong in a lot of cases. Okay. So the main targets for anti-epileptic activity here, we're going to find pretty similar sort of targets. We might have covered some of this with Professor Kaplan just a little bit ago. We're going to talk about our sodium channel blockers, look at medications that work on calcium channels, because normally calcium is more stimulatory or inhibitory. Usually stimulatory, right? Just like with the muscles, it stimulates contraction. Here we're going to find it helps to stimulate action potential firing. We'll talk about GABA enhancers, so things that actually help GABA to work better. We'll look at things that block glutamate, because we said glutamate's excitatory, so if you can block that, that also helps to increase that threshold there. We'll talk a little bit about carbonic anhydrase inhibitors. Have we covered any of those drugs before? Perhaps. You know where we talked about them? Glaucoma, yep, I heard that. And then what else? It's a diuretic, right? So we talked about, anyone remember the specific drugs? Acetazolamide is a big one, right? So acetazolamide can be used occasionally. If you recall, acetazolamide helped to block reabsorption of what compound? Bicarb, right? So you peed out your bicarb. What do you think it does to your serum pH? It decreases it, right? Just like what a ketogenic diet does, right? So you can kind of see how that can be useful for helping to increase that seizure threshold there. Look at hormones. That's not really going to be a big thing we'll talk about here, but it's just an important consideration how introducing hormones into patients can affect their seizure disorders, right? So when would we possibly introduce hormones for a patient? Maybe thyroid issues, yeah, for sure. What else? Menopause, or in younger patients, birth control, right? Actually, one of the big things you'll note here as well with these medications, a lot of them are teratogenic. What does that mean? To harm a developing fetus, right? So again, this is really important because you want to make sure these patients are not getting pregnant unless you've come up with a plan with them, right? So in some cases, they say, hey, I'm looking to start a family. Maybe we want them to come off of their medications for a period of time, or maybe switch to something that's not going to be as teratogenic. Those are important considerations there, right? Because when is it most important to know when drug exposure is happening to a fetus? First trimester, right? Does everyone know the second? Do they have like a light shine down upon them that says, hey, you're pregnant? The second of conception? No, they may not know for 6, 8, 12 weeks, 38 weeks in some cases, right? But generally, that's when a lot of that organogenesis is happening, and they don't know they're having that drug exposure, and it can be really, really bad for the patients and the developing fetus there, right? And we'll talk about some medications where we don't really know why it works, but it just happens to work. So, looking at our sodium channels, if you recall this action potential, looking at this, you can see this is very similar to what we talked about with the cardiac stuff last semester, right? And so you can see here that normally that resting membrane potential is being maintained by that sodium-potassium pump, but what causes that acute sort of depolarization to occur? Sodium channels are opening up, right? So sodium flows which direction? Goes along a concentration gradient, right? And what's our serum sodium levels typically? It's like 135 to 145. In the cell, it's much less than that, right? So it flows into the cell, and that's what causing that depolarization. It's that phase at zero depolarization that occurs there, right? And then you can find that as opposed to sodium, which is high on the extracellular content side, potassium is high on the intracellular content side. And so potassium can be another big one where these channels will open up, and that will also help with that repolarization phase that occurs there, right? We talk about potassium channel blockers, how that can affect the repolarization of, say, myocytes. Well, similarly here, we can find some medications might affect potassium channels here as well. Again, once I get to this kind of hyperpolarization phase, this is where the refractory period is occurring here, where again, no other signal can come along and trigger off of their action potential until they're back at that resting state, right? And again, we remember, if you recall back to the cardiac stuff with the sodium channels, they kind of have three different states there, right? There's the resting state where they're ready to go. As soon as an action potential comes along and triggers it, they're good to go. They have the active state where they're actually open, allowing stuff in, and then have this sort of refractory period, this inactive state. And again, depending on the drug, they may affect different versions of that. I'm not going to get so granular onto that, but just know those are the different states that sodium channels will be in. Okay, so looking at this, you can find some of the medications that will affect different sites on those actual sodium channels themselves, right? And we'll cover these medications here. And again, it's important to know that some of these will actually have multiple mechanisms, right? So some of them work on sodium and calcium, maybe some potassium, maybe some GABA. They kind of can vary it up a little bit. We'll look at those examples there. But again, by blocking the sodium channels, what does it do to that phase zero depolarization? Inhibits it, slows it down, or maybe prevents it altogether, depending on how much drug is around, how much it's affecting that channel there. So again, by slowing down that phase zero depolarization, again, can help to prolong that refractory period, maybe prevent that neuron from firing off, slow everything down, right? Because again, when you're having that active seizure, all the neurons are just kind of firing sort of a scatter shot. Here you want something to try to slow that down and to stop it. And this is one of the ways we can do that. Okay. Going into our calcium channels, we know there's a couple different types of calcium channels, right? So in the brain, we find there's different ones like L, N, and T-type calcium channels there. And again, normally by having calcium moving through those channels, you'll have a partial sort of depolarization. Not as strong as, say, sodium would cause, but calcium can cause some depolarization to occur there. And actually what you end up finding is that by affecting certain types of these channels, you can affect different specific types of seizures, right? So for instance, anti-epileptic drugs that are just working on the T-type calcium channel, so there's one called ethosuximide, is really useful for an absent seizure, right? You know what an absent seizure is? I induce it almost every single class period with you guys. It's like 62 simultaneous absent seizures. Sometimes you wonder what your superpower is. That's mine, right? But anyway, so we have specific drugs that just work on that target, and guess what? They're really good for that type of seizure. Not really good for much other things, right? So that can be how specific it ends up getting into in some of these cases there. So again, we'll find that different drugs like valproate or valproic acid is also going to be useful for helping to block that. And I'll cover those specific examples as we go along. But again, similar sort of process as the sodium channel blockers. Now, GABA, there's two main types of GABA channels. There's GABA A and there's GABA B. GABA B we're going to talk more about when you talk about like pain management and muscle spasticity and things like that. So if you think about like muscle relaxants, a lot of those drugs work on GABA B. Our main thing we're going to focus on here is going to be GABA A. And if you recall what it said, when you activate a GABA channel, that allows what to flow in? Chloride, right? More chloride is going to flow in. That's a negative ion. It's going to hyperpolarize that cell and again make it more difficult to have that action potential there. There's a couple ways we can affect this, right? You can have drugs that directly open the channel. You can have maybe drugs that help say GABA to work better. They can enhance the effects of GABA. Some of them may be able to help maybe prevent the breakdown of GABA, right? So maybe if I prevent the breakdown, have more of it around, that can be useful. A lot of different ways we can actually affect this. So we'll talk about GABA B much later on. Those are more linked like potassium channels, but we'll talk about that in terms of muscle spasticity in a couple of sections. Now, as I mentioned here, we can do things like preventing the breakdown. So for instance, by modulating this enzyme here, this glutamic acid decarboxylase. That's normally something that helps to break down GABA. By increasing the amount of GABA available, obviously it's going to be working better, more able to interact with those channels and allow more chloride to flow in, right? Or perhaps I can do things like block the reuptake of GABA, right? Now, we'll talk a lot about this when we talk about depression. We'll talk about SSRIs. Those are selective serotonin reuptake inhibitors. By preventing the reuptake of something, more of it stays in that synapse, and guess what? More of it's available to interact with the channels there. This is similar, where you can block the reuptake of GABA and allow more of it kind of sit around interacting with those channels. Other ways you can do it, we can try to actually help to inhibit metabolism. There's another enzyme called GABA T or GABA transaminase that can also work on that. They can help to prevent breakdown of GABA, leaving more of it around. And then other things, and this is probably the most common thing we're going to find here, they're going to bind to the actual channel allosterically. Anyone know what that term means? It's a different site, right? So kind of pulling back to your undergrad chemistry stuff or biochem. But allosterically means it's going to bind to a different site than where GABA would bind, but it helps GABA to work better. It causes a conformational change in the protein where GABA actually is going to have an easier time binding. And the more it binds, the more likely it's going to cause those channels to open up, chloride flows in, and boom, stop your seizure. So this is where things like our barbiturates, like phenobarbital, and then benzodiazepines are going to come into play. These are going to be really big ones in terms of like acute seizure management. And we'll talk about this from some other uses as well. Again, looking here, we have a neuron that releases GABA, and then we have some GABA channels that are here. So for instance, things like benzodiazepines and barbiturates, they can bind to different sites here that allow for GABA to bind more readily to it. And we can do things like blocking the reuptake or maybe blocking the breakdown thereof. Again, more GABA means more activity at the channel, more hyperpolarization that occurs. And then glutamate, this is one that's going to be kind of more of an up-and-coming one. They're finding more drugs that are affecting the glutamate process here. But anything that's going to be blocking the activity of glutamate at those channels is going to help to be more inhibitory, right? Find too much glutamate is very excitatory, it can lead to seizures. We want to try to prevent that as best we can. So we're going to try to decrease the amount of inward flow of sodium, calcium, all that to help prevent those action potentials from occurring. There's actually a lot of different types of glutamate receptors that are out there. I'm not going to get super in-depth on a lot of these, but they all have different actions. They all do different things here. So for instance, I like the NMDA receptor the best because it actually has to do with one of my favorite drugs to give to patients. So if you block the NMDA receptor, you can actually cause a dissociative sort of anesthesia. Basically, it's like causing an out-of-body experience for your patients. And know any NMDA receptor antagonist? Another name for it, special K. Ketamine, yeah. So we use that a lot for procedural sedation. We'll actually be able to knock our patients out. They still breathe. They can still respond in some limited cases there, but they're not there, right? So they're not there when you're setting their bones or suturing them, whatever you're doing. But they can have very different actions depending on which type of glutamate receptor you're going to be targeting, and different antiepileptics may be shooting for different ones here.
Is that what you use when you do like brain surgeries, like for musicians and stuff, when they
Perhaps. I'm not sure how often that's done, but I don't know, perhaps. The nice thing about ketamine is that it doesn't really hit your respiratory drive. So you can have patients, as I mentioned, they can still respond in some limited cases there. Some of them might still moan out in pain and things like that, but there's really no connections. They're not really aware of what's going on there. So whenever we give kids ketamine for, say, like a fracture or something we're going to set, we'll always tell them, hey, like, what's your favorite thing to do? And they're like, I love playing baseball. And they're like, just think about playing baseball with, like, I don't know, Mickey Mantle, whoever a famous baseball player is. I don't know sports very good, but and then they'll come back out of it and you're like, how was it? They're like, it was awesome. That was the best experience I've ever had, So it's kind of funny because we'll have kids coming like from Disneyland to get injured, and then we'll give them ketamine and always have really good times with Mickey Mouse. Usually the ketamine's probably better than the actual park itself in some cases. Anywho, though. We can see here is different drugs are going to work at different glutamate receptors here. We're going to find they have very different actions. So for instance, things like levetiracetam or Keppra is like a really, really important up-and-comer that we're using for a lot of patients. We'll talk about that more specifically in a little bit. Okay, and again, I'm not going to get super granular and ask you, okay, well the AMPA does this action versus the kinase one. Just know that there's different actions. Different drugs may be working at different types of glutamate receptors. And again, you're going to find that for some drugs, we know a ton about them. We know their exact mechanism. We know all about their kinetics, etc. There's going to be a lot more detailed there, and I'm much more likely to ask questions about that. Some of these other ones, we may be like, well, we don't really know why it works. I'm not going to ask you a question on the test to say, like, well, how does this drug work? And then I'm going to put on there, we don't know. Like, it's not really a good test question, right? So just keep in mind that's kind of how we're going to be focusing on this. If I'm focusing a lot of time on a specific drug, I'm probably going to be more likely to ask questions from that drug itself, right? So no new news for any of you, because you've already taken my class before, right? Anyway, and again, you can find that while we may not give hormones specifically to treat seizure disorders, just know they can have an effect, right? So if you put a patient on oral contraceptives, or maybe they're going through hormone replacement therapy, whatever the reason may be, you can find that things like estrogens tend to increase seizure activity more likely than not, versus progesterone tends to have an anti-seizure sort of activity there. So different patients may respond a little bit differently. Just know that's something you may find some interactions with. And then we mentioned the carboxyl hydrase inhibitors. We don't use these super commonly anymore. If we need to acidify the patient, usually ketogenic diets are the best way to do that, but you may find it used very rarely. Okay, so getting into the specific medications there, and is that clock broken? I think it's broken. Oh boy. Okay, I got 4 minutes, so I'll at least get into it. So looking at anti-epileptic drugs, you're going to find that there's over 20 that are available here in the U.S. I'm not going to cover every single one because some of them are very niche sort of uses. They're not going to be super common, or maybe they're just a lot of them are still brand name and they're very expensive, so you don't see them used as commonly. Some of these are older than dirt, and I'll talk quite extensively about them. Typically, though, the problem is that when you're, say, doing say you were trying to introduce a new seizure medication onto the market today, right, and you're doing your clinical trials, is it reasonable to give a patient with a known seizure disorder placebo versus your medication? Not generally, right, because we have good medications that are used to treat those seizures already. That's the gold standard. So frequently it's very difficult to do studies like that, and so we don't really have a ton of like head-to-head therapies to know like which one's better, and oftentimes they're not studied as monotherapy. They're usually studied as an add-on drug, so we don't know how well they work just being used by themselves, which is kind of tough. And so a lot of them may be using off-label uses, right, so it's not FDA approved, but they may be used off-label as monotherapy. We'll talk about some cases where that happens a little bit later. But generally the newer agents are going to be pretty comparable to a lot of the older ones. They do, in some cases, lack a lot of the side effects we're going to see. So we'll talk about some that are a little bit more favorable in terms of their side effect profile than some of the older ones there. But again, ultimately it's very dependent on the patient, the provider, kind of how they respond to it, depending on a lot of different factors there. Let me see what questions we have here. Can you tell us another dad joke? We missed them. No, but I will tell you I had a travel story over the break. I actually got to go to Stockholm, and I was really not excited about it. I was like, why? Who wants to go to Stockholm? But after I was there a while, I really started to like it. Yes. How was your break? It was good. I missed you. I missed you all too. I haven't seen you guys since last decade. I mean, come on. All right. Okay, so let's continue on. So we have our first anti-epileptic drug. Here's Phenytoin, or Dilantin is the common brand name you're going to see for that. This one is both available IV or orally, so this can be useful for, say, patients maybe can't take oral medications. You could do it IV in the hospital, or if they're having an acute seizure where you want to treat that, then you go ahead and give it to them IV. And so it kind of goes back to thinking about, well, what kind of routes of administration are useful for a patient who's having an active seizure? Like, can I give them anything orally? Why not? They can aspirate it, right? Exactly. They have no kind of control over themselves, and they may aspirate it. That can lead to some issues there, right? So what other routes could I use? IV is good. What else? Intramuscular you could use. What else? Rectal is another common one, right? So for a long time we're using intrarectal diazepam. That's in a common. We'll talk about that drug a little bit later on. What's another route you could use? Intranasal. That is becoming much more common now. So you're starting to see a lot more intranasal use of medications to treat these acute seizures. And in fact, if you had to think about it, would you rather, if you have your loved one on the floor having a seizure, would you rather try to give them something rectally or nasally? It's a lot easier to give something intranasally. It's a lot easier to do it, right? So because of that, that's how we're starting to move more towards that. But we'll talk about intranasal use. Actually, I have a video on my channel somewhere where you can find an actual whole video just about intranasal drug use if you are so inclined, or if you need a sleep aid or something like that, you can go check that out. But anyway, so Phenytoin is going to be working via blockage of these sodium channels, right? So very straightforward mechanism. Block sodium channels, prevent Phase 0 depolarization, you prevent the action potential, right? Some things to know, this one is very sort of temperamental from a drug interaction sort of standpoint. So for one, it's highly protein bound, okay? It's about 90% protein bound. What does that mean for us? How much of it's active? Only 10%, right? Whatever's free is physiologically active, right? So what would happen if I say you had a patient who maybe had hypoalbuminemia, right? So it binds to albumin, you have low albumin levels. What do you think happens to that fraction? It actually increases, right? So maybe I go from say 10% to 15%. Is that a big deal? Yeah, because that's a lot more drug that's now available to interact with those sodium channels. So this is another one we're going to talk about in terms of therapeutic drug monitoring. We have to look at the levels. We're going to talk about total levels, which is measuring everything in the blood, and then we'll also look at what we call free levels. And that can be another really important thing to look at, to consider, like, well, how much of the drug is actually available to interact with those channels, and that can be a little bit more indicative. Because you can have a patient who has a normal level, say 10 to 20 is a typical phenytoin level, and their level's 15, so you say, well, they should be good to go, right? But they're having a lot of side effects. Could be related to that free fraction being higher, right? So again, highly protein bound. If you have another drug that comes and kicks it off of the protein, same problem you're going to run into, right? More of it's free, more of it's able to cause problems. Now, it also undergoes what we call Michaelis-Menten kinetics. And so this is kind of a very kind of minute point, but it can have big ramifications, right? So basically, if you recall back to pharmacodynamics, we talked about phase 0 versus phase 1 metabolism. Anyone remember the difference? Thank you for being honest and saying no, you don't, right? Phase 0 metabolism means you're always metabolizing the same amount of drug per unit of time, right? I'm always metabolizing 20 milligrams per deciliter of phenytoin, right? Every hour, it's always the same. First order kinetics was where you're metabolizing the same percentage of drug per unit of time. It's always 10% per hour. Remember how those graphs look? I'll show you an example of that in a moment here, but what are the majority of drugs following? First order kinetics, right? They follow phase, first order kinetics. We'll look at that in a second. But the majority of them are going to do that, right? Which means that as I have more drug in the system, just more of it gets metabolized, and so you get that curve that we'll look at in just a moment here, which I think here, right? So first order kinetics, although it is pointing that we're talking about the first order, right? Yep. Anyway, so yeah, the first order kinetics, most drugs are going to follow this versus zero order kinetics, right? So what's interesting about phenytoin is that actually, depending on the level that you give, it will actually switch from first order at normal therapeutic levels over to zero order, okay? And so that means that the metabolism, the actual rate of metabolism, actually kind of goes to a standstill at a certain point, right? Because with most first order drugs, as I give more of the drug, a higher or the same percentage, but a higher amount is being metabolized for that half-life, right? What you end up finding is as it switches over to zero order kinetics, and I'm only metabolizing a certain amount because I've saturated all those enzymes. What do you think happens to the half-life of that drug now? It gets a lot longer, right? Because all my enzymes are busy; they can't metabolize all that drug that's sitting around there. So I'll give you an example why this matters. So we had a patient one time who was in the ER who was presenting with an acute seizure. They had a known seizure disorder, but they've been non-compliant with their phenytoin, right? So what do? Give them phenytoin, right? So we ended up giving them, the resident wrote for a bolus of phenytoin, got them back a loading dose of phenytoin to get them up to what? Steady state, right? So again, so there'd be a nice steady state, hopefully preventing those seizures from occurring there. This happened around, this was in the morning times around shift change. Anyone know what time shift change occurs? 7 and 7, right? So typically what would happen is you'd have the residents would change over, the nurses would change over. This is where we still had paper documentation at the time. And so basically the dose was given by the night shift nurse, but it never got documented. So then the morning shift nurse came on, looked at the orders and said, okay, I got to give this patient phenytoin. The patient didn't know any better. And guess what happened? The patient got a double dose of phenytoin. So now it switched over from that first order kinetics over to zero order, which means the half-life is now super extended. Also, the level is now twice what it was beforehand, so the patient is super dizzy, very nauseous because of the side effects we'll talk about in a little bit. And basically, the half-life was so long that we couldn't send her home because she's going to be at that level for days, essentially, right? So we ended up giving her an antidote to try to get the level down a little bit faster, but just goes to show you to be really careful because, again, with most drugs, if you accidentally got a double dose, it really wouldn't be that big of a deal. Could be, depending on the drug, but for this one, because it switched over that connects, it was not going to be days long admission versus her just getting sent out from the ER if she just gotten the one dose. Okay, so big kind of medical error that happened there. Anyway, so other things to note here, it is metabolized by CYP2C9 and 2C19, which means it is very available for a lot of drug interactions that come by and can interact with that, maybe inhibiting those enzymes there. And also it can induce enzymes as well. So it induces 3A4 and induces 2C families. So what do you think that means in terms of drug interactions? Say, for instance, I had a patient who's taking, say, warfarin along with phenytoin. What would phenytoin do to warfarin's metabolism? If it's inducing those enzymes, it's increasing warfarin metabolism. What do you think it does to the patient's INR? Up or down? Makes it go back down, right? Because again, I'm getting rid of more warfarin. So less warfarin around means that I have more clotting factors being made, which means my INR comes back down to the normal of 1, right? So again, think through the multiple steps here to kind of get to the point, okay, if I introduce this enzyme inducer, what is that going to do to my monitoring parameters? What's it going to do to, in terms of side effects, efficacy, et cetera, right? Anyway, and so typically this is used for a lot of different types of seizures, very broad acting. You can work on a lot of generalized and partial seizures. We'll talk about one drug in particular that works for absent seizures, but really most of these are going to work for a variety of different seizure types, so a very broad spectrum, right? So again, major side effects, if I'm slowing down those sodium channels from working, slowing down those neurons from firing, what do you think a major side effect of these drugs are going to be? Sedation, altered mental status, right? You can see, especially when you're starting up with, if you go kind of too fast with the titration, you can definitely end up seeing that. Over time, that does get better, right? So you're going to find that patients will get kind of more tolerant to those effects to where they won't be kind of zonked out all throughout the day, right? Some of these drugs are going to be worse for causing that sedation than others, but certainly, again, if the level's too high, titrate up too fast, you can certainly see that with these patients here, right? Other things you can find, find things like hirsutism, right? What is hirsutism? Abnormal hair growth, right? So you may get like, all of a sudden start growing a mustache or something when you normally would not. It can be a problem for a lot of patients, right? So hirsutism is an issue here. And you can also find gingival hyperplasia as another really common adverse effect. So you got to make sure the patient has really good oral hygiene to try to make sure you keep the gums from kind of getting too overgrown there, okay? Other things causing vitamin D deficiencies, which can lead to osteomalacia, especially in older patients, maybe who are hitting menopause and things like that. And again, a lot of these drugs can also induce a lot of skin manifestations. I'll talk about this kind of bring it all together a little bit later on. But in general, you can see things like rash are quite common with phenytoin. You can also find Stevens-Johnson syndrome. We talked about that before. What is that? Yeah, basically the skin starts sloughing off. It can be quite fatal if not caught and managed early. This is not going to be the worst one that causes that, but certainly that is a risk, right? So any kind of new rashes, blisters, ulcerations, anything like that, it needs to be a warning sign, hey, stop taking the med, come on and get checked out, right? But for a long time, this was a first-line medication. It worked very well. We used it for most patients who had a seizure disorder. It's starting to go by the wayside a little bit, mainly because of these drug interactions, side effects, etc. We'll look at some things that are alternatives. But certainly, if I have a patient who's coming in for an acute seizure and say they're in status epilepticus, this will still be, say, second or third down the line of drugs I'm going to be using here. So it'll still get used quite commonly. Okay. Again, talked about the kinetics issues there, so we'll review that. Now, I'm not going to ask you dosing. Obviously, that's not changed from last semester, but just to give you an idea that we do use loading doses, right, to get us up to steady state initially. Otherwise, you don't want to wait 4 to 5 half-lives to get up to that steady state because the patient may be seizing that whole time. You don't want that. And again, you can find that we will then put them on a maintenance dosing afterwards in order to keep them maintained at that steady state, hopefully. As I mentioned, with the therapeutic ranges there, I'll give you the range on the test, but your job is to make interpretations of that. Usually, the total levels around 10 to 20 or so. And then if you need to, if the patient maybe is having breakthrough seizures, or if you want to check to see maybe they're having a protein binding interaction or they have low albumin levels, you can then get a free level. And that just looks at what's actually physiologically active. And this level makes sense because I said it's about 90% protein bound, so 10% of 10 to 20 is 1 to 2 essentially, right? So that's what we'd be looking for. So, but again, remember, as the levels go up, the half-life is going to increase, and so that's, again, where when those patients kind of make that switch, once they've saturated all those enzymes, that's where the half-life can get really prolonged, and they can kind of get themselves into some trouble in terms of side effects. So again, other reasons why patients may have low albumin levels, some of it may be related to nutrition. If they have chronic renal disease, this can also lower the albumin levels. If there are multiple anti-epileptic drugs, this can also be an issue where you may find that other drugs are kicking phenytoin off the protein. So those are things you all want to be really considerate of. Okay. Okay, so there's another version of phenytoin called phosphenytoin. Now, phenytoin itself doesn't like to go into solution very well, and in fact, in order to get it into an IV preparation, we have to put it with things like a lot of different types of alcohols. We have to put it at a pH of 11, and so that can be very, very bad in terms of its effects on the veins. So this is another case where it can be a very strong vesicant, right? We talked about that with chemo drugs last semester, right, where things that extravasate can cause severe tissue injury. And here's an example of what they call purple glove syndrome. This would be a case where phenytoin extravasated out of a vein and caused severe tissue necrosis, just because the stuff is so harsh in terms of all the different compounds that are in there. Also, you can't give it IM because, again, it causes similar tissue injury there. Okay, so as an alternative, we have a more water-soluble formulation called phosphenytoin. Basically, if you just took phenytoin, pop the phosphate group on there, it increases the water solubility, and it still works pretty well. Gets into the system, your body will cleave off that phosphate, and now you just have regular phenytoin to work with now. Okay, so because of that, now we have a form that we can give IV, or we can give intramuscularly. We also have a form that's much safer on the veins, right? Which is good for kids too, because if you think about their veins, they're very fragile, much easier to extravasate than what you would see with an adult patient. So phosphenytoin is kind of our go-to parenteral form of phenytoin. For maintenance dosing, for oral use, typically normal phenytoin is totally appropriate, right? Just if you note here, if you ever see that it's dosed in PE, that just stands for phenytoin equivalence. Essentially, because phosphenytoin is a bigger molecule, it just weighs more, right? Because it has that extra phosphate group on there. But basically, the way they correct it, they just basically dose it in phenytoin equivalent. So that way, a gram of phenytoin is equivalent to a gram of phosphenytoin PE, right? So we don't have to do any dosing conversions because that could lead to some dosing errors and whatnot. Okay. Okay, next we have a drug called carbamazepine or Tegretol. This is going to be another one working as a sodium channel blocker. This one's going to be sort of pulling double duty as when we get into the behavioral health section. Some of the anti-epileptic drugs are also good as mood stabilizers, right? Who do we use mood stabilizers in? Patients with bipolar disorder, right? So this is helpful to help bring them down off of their manic episodes or prevent those kind of big spikes in their mood, right, in their affect. So carbamazepine is a common one you're going to see there. There'll be a few more that I'll kind of make note of, but we'll cover those again in the behavioral section later on. So this one also is rife with drug interactions because this one actually can auto-induce its own metabolism, right? What do you think that means, auto-induction of its metabolism? Yeah. And induces the enzymes that are metabolizing. So that way, if I gave the same dose of carbamazepine, you'd actually see the blood levels fall down over time because they have more enzymes available to metabolize the drug. So you actually have to titrate up on the dose over the course of several weeks in order to make sure that you get them at a nice steady state balance where they've overcome that inhibition or that induction of the enzymes, and you get to a nice steady state level there. This will be metabolized by CYP3A4, so you do have to watch out for interactions there, but it also induces 3A4, 2C9, 2C19. So again, a lot of drug interactions, can be really careful. Anytime you're adding one of these meds on, always got to double check their profile to see if there's any other interactions that are going to come up, okay? Most of these are going to be metabolized through the liver, so you can see some LFT increases. You can see hepatotoxicity, so you do want to watch for that. Phenytoin, almost entirely metabolized through the liver. Carbamazepine, similarly so. Got to watch for LFTs for those patients there. Okay. Now, it's interesting. Another kind of interesting side effect of carbamazepine, it can actually cause SIADH. Know what that stands for? Syndrome of inappropriate antidiuretic hormone release, where basically they are releasing too much antidiuretic hormone, and what does that cause? Causes hyponatremia, right? Because again, you have that increased thirst reflex. You're holding on to more water in the kidneys, such that you're diluting out a lot of your sodium. Well, guess what hyponatremia can present with? Seizures, right? If you come in, your sodium is 116. Seizures may be the thing you're actually presenting with because of that, right? So you have to be really careful. You're thinking, well, is the drug maybe the level too high causing seizures? Is the level too low and the patient's just having a breakthrough seizure? Or is it because their sodium is now low, right? So these are all questions you have to ask yourself. And so sodium would be one thing you definitely would want to monitor for. There is a cousin to carbamazepine called oxcarbazepine. Is more likely to cause that, and so you definitely want to monitor sodium for both of these medications here, okay? Other things you can see rarely do want to monitor things like their CBC, because you can see things like thrombocytopenia, leukopenia, could be a risk for infection, things like that. Again, here's an example how that dose titration schedule over the course of a month, you gradually increase the dose. And at this point here, you get a nice balance between the induction of the enzymes and the level, such that you get a nice steady state to where the patient will be maintained at their normal therapeutic level. Usually around 4 to 12 or so is a good level for carbamazepine. So as I mentioned, a cousin to that is oxcarbazepine, works very similar to carbamazepine. The only difference here is it causes more SIADH. So again, you got to monitor those sodium levels. Fewer adverse drug reactions, fewer drug interactions than you see with carbamazepine, which is nice. So it's a little bit more tolerable. Again, just watch out for that sodium there. This is another one you're going to see used as a mood stabilizer for certain patients. You see them on trileptal. It could either be for seizure disorder or it could be for bipolar disorder. Here's another common one you're going to see used again for both bipolar and for seizure disorders. It's going to be valproic acid. You may see like sodium valproate, divalproics. There's a lot of different names that may come by. The brand names are usually things like Depakote or Depakine, things like that. This one is going to be a little bit more wide-ranging in terms of its mechanisms here. So it does inhibit sodium channels. You're also going to find some calcium interactions there. You're going to find it can do things like enhancing GABA. So it's nice from that standpoint because it works pretty well via complementary mechanisms to work better for seizure control. It's also pretty well tolerated. We find some GI effects, some sedation associated with this, but for the most part, pretty well tolerated. And for a lot of patients who are getting started, say, on a mood stabilizer, valproic acid tends to be a pretty common one for a lot of them. Things to note, though, this can cause pretty significant hepatotoxicity, so you got to watch your LFTs, and it actually can be a cause for pancreatitis. So again, something that's kind of uncommon, but a drug-induced cause for pancreatitis, it would be something you want to keep up on your differential, right? Can see some bone marrow suppression there, so thrombocytopenia is possible, so again, you want to watch out for that. This will inhibit CYP2C9, so again, some source for drug interactions. And then there's this UGT system here. That is going to be more specifically affecting drugs like lamotrigine and lorazepam. We'll talk about that a little bit later on. This one's less clinically significant than I would say than the CYP2C9 inhibition there, right? So be aware of that. And again, now we're starting to see some of these are inducers, some of these are inhibitors, so you got to be aware of how that's going to have an effect on susceptible medications there. Okay, this is a big one. It causes neural tube defects. So this is one of the big ones I mentioned that are severely teratogenic. Really want to make sure your patients are going to be not getting pregnant while they're on valproic acid, or if they want to become pregnant, they need to find an alternative medication because this will cause some big issues for that patient, right? Okay, up next we have our benzodiazepines. You can call like benzos. This is a very wide-ranging group of drugs. You can use this for seizures, certainly. What else can we use benzos for? Not depression necessarily, more specifically anxiety, right? So the ever-constant bedfellow to depression is anxiety. This is really good for acute panic attacks, social anxiety, all kinds of things like that. But again, the mechanism's identical between the two there. So basically, benzodiazepines will bind to a specific benzodiazepine receptor site on the GABA A channel and will allow it to change the conformation of the protein to allow GABA to bind more easily unless you have more chloride flowing in. So this does not directly open the channel, but it allows GABA to more easily bind to and open that channel. Okay, chloride flows in, you have hyperpolarization of the neuron there. Okay. Now, we'll talk about this again in the behavioral health section coming up at a later section of the course here, but here are the common ones you're going to see used for specific seizure disorders. So for instance, like diazepam, that was marketed as Diastat, which is a rectal gel that's used quite commonly. Now, and again, whenever you're prescribing something like this, you have to think about the patient education, right? So again, make sure they have lots of information, handouts, pamphlets, whatever they need to educate and walk them through the process, right? Make sure they can. You guys ever heard of the teach back method? What is that? I show you something, I teach you something, and then I have you explain it back to me, right? So make sure they can do that, right? Because you don't want the patient, the caregiver for that patient, to have to figure out how to use a rectal gel when they're, say their child, for instance, is having an acute seizure. It can be pretty harrowing. So even little simple things like, for instance, what's really important for Diastat is they have like a little packet that has lubrication in it, right? Because guess what could happen if you don't apply lubrication when you're inserting it rectally? Rectal traumas, right? And so you don't want to cause that. And again, if you're in a really kind of harrowing experience, your kid's seizing, that can be easy to forget those little steps there. So education is really important. Other ones we'll see pretty commonly, lorazepam is probably like the go-to IV anti-seizure medication. If you're having an acute seizure, Ativan is probably going to be the one you're going to get most commonly. You can still see it used orally, but IV is kind of where it gets a lot of its bread and butter sort of use, especially ER hospital sort of settings there. But Versed is definitely going to be used as well. So you see a lot more midazolam use coming up nowadays, and even little things like how do you store the medication. So for instance, say you're working on an EMS rig that's responding, and you have to think about like, well, how do you store the medication? Especially here in Florida, it gets pretty warm. Lorazepam has to be kept cold, otherwise it actually will break down. And so if you can have a medication that can be stored at room temperature, then that's going to be a lot better in terms of like stability, storage, cost, things like that. So now you're seeing a lot of EMS units switching over to using Versed versus Ativan, right? Not important for you to know for a testing purpose, but just some of the considerations that we will think about when we're deciding what kind of medications to use for our patients here. Because again, any of these can work equally efficacious. They're all doing the same thing, but little things like that can make a difference. Okay, clonazepam, we see this used pretty frequently for a lot of pediatric seizures. You may see adults and whatnot using this for kind of chronic anxiety. And then actually here's a new one called clobazam or Onfi. That's a newer oral agent. I'm seeing a lot of kids being transitioned over to by some of our neurologists. Now, all the meds we've looked at so far have not been controlled substances. This is the first group that will be. So these are all C4 medications. So what does that mean in terms of prescribing? Can a PA prescribe benzos in Florida? What do you need? Got to have a DEA number, right? For one thing, you have to go through all the appropriate training and whatnot for that, right? All the education you signed up for it. What does it mean in terms of like how long of a prescription you can give them for? How many refills can you give them? How long are these scripts good for? Because a normal script is good for how long? A year. See, 3 through 5 are only good for 6 months, right? So I can only give them 6 months of drug at a time, give them the original fill plus 5 refills, versus say something like Phenytoin, I give them a whole year's worth at a time, right? So those are considerations to put in there. Because if I get a script, it came in, say I was working at a Walgreens, and my life has made some turns, and I'm working at a Walgreens, and I get, I hope that never happens, but you never know. But if I get an Ativan prescription that comes in with 11 refills, I'm going to be like, what's going on here, right? One, I won't honor that, and then I may have to call you up and say, what do you actually want on this, right? So little things, because again, maybe you just wrote 1 refill on there, and then your patient decide, well, I kind of want some more than that. Just put a little extra 1 on there, right? So how would you write out your quantities and your refills when you're doing this? Write out textually, right? So I can say ONE instead of just saying 1, and that way it prevents some of that tampering there, right? So again, considerations to make when you're prescribing a controlled substance versus say some of the non-controlled substances. So you're going to find the kinetics are going to be very dependent on the specific med the patient, or depending on which agent the patient is going to be on there. So some of them are renally eliminated entirely. Some of them are much more hepatically eliminated. Some of them are more fat versus water soluble, right? So when I say fat soluble, what could that imply for the actions of the medication? Do you think it helps it to work better, less well, faster, slower? Why slower? It's fat soluble. Well, think about where are these drugs working at? The CNS. So what does it have to do to get to the CNS? Cross the blood-brain barrier, right? And so typically things that are fat soluble, they cross much more easily. So it actually behooves us to, in some cases here, to use a fat soluble drug because it gets into the brain faster. It could treat the seizure a little bit quicker, right? Fast in also though means fast out, so that may be not great. So for instance, midazolam, Versed, pretty fat soluble, works very quickly, versus Ativan or lorazepam is more water soluble. What's nice about that though is that if I give that dose, it takes a little bit longer to get into the CNS, but also sticks around for longer because it's a harder time crossing back out, which means that I may have less likely to have recurrent seizures down the road, right? So maybe trade off a little bit of onset of action now for preventing a seizure, say 30 minutes, an hour from now. Little considerations we make there, right? And again, it may not be super apparent because when you go to work somewhere, they just say, well, we just use Ativan here. But some of the whys are things you want to kind of know about. And it makes sense if you know the kinetics and the action mechanisms, etc. Okay. Anyway, these are the go-to agents for acute seizures. So these are like, this is your albuterol for an asthma attack. Benzos are this for your acute seizures, right? And again, many routes that are available. A lot of patients used to be on rectal diazepam for outpatient use. Now we're switching them over in a lot of cases over to intranasal Versed. And so basically we'll give them a syringe. It's the IV product, right? So they'll have to draw it up, and then they actually have an atomizer that will go on the end of the tip of the syringe, and that allows to form this really nice fine mist that will just be inserted intranasally, and that will have very good bioavailability, right? Because again, does it go to the liver if it gets absorbed intranasally? No, it bypasses first pass effect, kind of similar activity to what you see rectally, just a lot easier in terms of administration. You don't have to worry about, getting their pants off and applying lubrication, all this kind of stuff. You don't have to think about it. You just have to put it in the nose and you're good to go. Okay. Now, in terms of side effects here, this is going to be the most common adverse effect is sedation, right? So think about this in terms of like alcohol, right? Because alcohol kind of does the same thing in terms of helping GABA to work better. It's going to cause sedation, cause amnesia. That might be a good thing in some cases, right? A lot of times we'll give Versed before patients go into surgery, right? Helps to calm their nerves a little bit. Maybe they don't remember kind of the preceding events. It can be useful there. But if they're taking it chronically for seizure management, that may not be a good thing. So again, you do become tolerant to those effects over time, meaning that while you may become pretty sedate with the first couple of doses, your body gets used to that after a while, okay? That also means that you have to be really careful when you're withdrawing or coming off the medications there, because what can happen? Your brain is so used to having that extra GABA effect around, if you take it away all of a sudden, less GABA, more glutamate activity, seizures, right? So withdrawal seizures are a really important thing there. Now again, if it's just like a one-time dose they got, you don't have to worry about it. But if they're taking chronically, then you definitely would want to have a titration schedule in place to wean them off the drug slowly to prevent a lot of withdrawal effects, right? Now it doesn't have to be seizures they're presenting with. What are some other things you might see if you had a patient withdrawing from, say, a benzodiazepine? They don't feel very good. They're maybe nauseous, maybe sweating, maybe tachycardic. There are other things that will eventually lead up to those seizures there, but just thinking about a patient who's withdrawing from alcohol, it looks almost identical between the two. And actually, guess what we give patients in the hospital who are withdrawing from alcohol? We used to give them PO beer with dinner, but hospitals moved away from storing a lot of alcohol, and so now we will actually give them benzos, right? So Ativan is a common one we'll give those patients who are withdrawing from alcohol because it's replacing what they're missing essentially, and that's that extra GABA activity there, right? Okay, so those are the benzos. Switching up a little bit, then we have the barbiturates, and so the main one you're going to see here used most commonly is going to be phenobarbital, and so this one is going to be working at a different site than where the benzos are, but does a very similar activity and will actually help to directly open and activate that GABA channel. So as opposed to benzos helping GABA to work better, this can directly open the channel itself. And so because of that, what do you think about in terms of sedation, which one's going to be worse? The barbiturates tend to be a little bit worse there, right? So this can cause the channels to open up, cause a lot more sedation in terms of that. So because of that, we don't really like it for chronic long-term use because, again, if you're zonked out all the time, it's not really going to be good from a compliance sort of standpoint, depending on the situation, right? So if you have a kid who's in school, they don't want to be zonked out, they fail in their classes because they're phenobarb. However, if they're in a state where they wouldn't be going to school anyway and they have very severe intractable seizures, this may be reasonable, right? And again, you have to worry about withdrawal effects. We'll get tolerant to some of these effects here, so these are things just to kind of note. This is really good for neonatal seizures. We give this pretty commonly in the NICU for kids who are having those seizures there. And this is also a controlled substance. This would be another C4. And actually, when I was doing, when I was on rotations, and I was a community rotation, and I was at a Publix, I actually had a patient come up and he said, "Here, get a refill." And I said, "What would you like a refill of?" He says, "Peanut butter balls." I go, "What?" Could not understand him. Had him repeat it 5 times. I looked at his profile. I was like, "Oh, phenobarbital," but a little bit of an accent there. Anyway, so this is going to be another set here. We're going to find a lot of drug interactions. Again, this can induce things like CYP2C9, 3A4, so another inducer. We'll have to draw levels down of other medications that's affecting it. And so typically this is not going to be a first-line med. This is going to be good for kind of adding on after other anti-epileptic drugs have failed, right? So this may be like a third add-on sort of medication in some cases there. This is going to be another one that's going to be therapeutically monitored. See the range there, 15 to 40. This one's pretty wide though. I've actually seen some patients who have been well controlled on, say, levels up to like 60, 70 in some cases there, and they get so tolerant to the sedation effects that they're just talking like me and you are right now, right? So it just depends on how the patient's going to respond to that. Now, within that same category of barbiturates is going to be pentobarbital or nimbutal. This one is used pretty rarely, but you may see it in some cases for patients who are in severe status epilepticus. They've failed 3 or 4 different drugs, and you just got to put them into basically a coma. So they call it a pentobarb coma. Basically, just completely zonk them out. Obviously, what's the big risk when you sedate a patient that heavily? The respiratory depression, right? So these are patients who are getting to be intubated anyway. Not every patient presenting with a seizure in the ER is going to get intubated, but certainly they have status epilepticus. You give them a ton of meds. It doesn't look like they're going to be able to really breathe on their own. They're going to get intubated, and this is where that pentobarb coma can come into play occasionally. I've probably seen this given maybe 2 or 3 times, more in the trauma sort of side of things, where especially patients with head injuries, this can be useful to help kind of lower that pressure a little bit and prevent seizures from occurring there. Okay, so those are the 2 barbiturates we'll mainly be talking about there. Moving on, next we have another drug called felbamate or felbutol. This one is not used super commonly, but can be useful as sort of an add-on agent there. The reason why we don't like it is because it can actually lead to things like aplastic anemia, which can be fatal in some cases there. This is really limited to refractory patients, right? So they've tried 3 or 4 different medications. There's nothing still working. This may be a useful add-on for those patients there. So ideally, you want to go with something with fewer side effects, obviously, and then as they start to fail, you can rely on something like this here, okay? Just kind of mentioned in passing. Ethosuximide is a good one because this is going to be used as the treatment of choice for absence seizures, right? So if I have a test question that asks, this patient has absence seizures, which medication would you like to start them on? You'd say ethosuximide, right? So again, this is a very particular case here, so little things like that are good to note. Again, not useful for other seizure types. So they have more of a generalized seizure disorder, partial seizure disorder. This is not going to be good for that, just for the absence ones. And again, that makes sense because it has a very specific mechanism, really only working on the calcium channels there, right? Next up, we have 2 drugs here, gabapentin and pregabalin. Now, you've probably seen patients on this before, but probably not for seizure disorders. And what have you may have seen this being used for? Neuropathies, fibromyalgia, things like that. So this is going to be 2 drugs you're going to see used much more commonly for neuropathic pain. And in fact, when we talk about pain later on, we're going to see that to treat neuropathic pain, you have to use things that are affecting the neurons. So you're going to find a lot of these anti-epileptic drugs can sometimes be useful for treating neuropathic pain. Gabapentin and pregabalin, they are structurally related to GABA, but they don't actually directly affect those channels there. However, they are thought to help out with, help out with things like calcium channels. They are thought to help enhance GABA synthesis, things like that. Note, these are going to be 100% renally eliminated, so if your patients have poor renal function, you do have to decrease that dose, otherwise sedation is going to be the main side effect you're going to see because of that. Interestingly enough, gabapentin itself is a non-controlled substance, whereas pregabalin is considered a C5. And again, that's the lowest controlled substance level. It's like, well, how likely is it to be abused? Probably not very, but again, when they were doing the clinical trials, they just happened to find that a few patients said, oh yeah, I feel a little euphoric. Sure, why not? And then they get marketed as a side effect, and then boom, they get a C5 on there from the DEA. So probably not necessary, but it is what it is. Next we have lamotrigine. This is another common one we're going to see used as a mood stabilizer as well, but this one is a little bit newer, is working on sodium channels, but also importantly has this glutamate release inhibition, right? So preventing glutamate from being released, it helps to alleviate some of that excitatory sort of effects there. Also may help with some calcium channels there. And again, when I say modulate, anyone know what I mean when I say that? Usually means we don't really know what it does. We're just saying it modulates calcium channels, and it sounds smart, right? An important thing here, though, an important interaction I've seen a lot of providers miss is that this actually will inhibit, or valproic acid or VPA is able to inhibit the metabolism of lamotrigine, and it's not uncommon that patients will be on both these medications here. So you have to be aware of the fact that you have to adjust your dose, and so I'll give you an example of this in a moment. But basically, in some cases there, if you're adding on lamotrigine, say to a patient who's on valproic acid, you'd have to start off at, let's say, half the normal dose, right? Versus if, say, you were starting it with an inhibitor, with an inducer, then you may have to actually double the dose, right? So it just depends on the situation there, on what you're going to be adding it on to. And frequently, if you were to say, look up a drug interaction report on LexiComp, and I urge you to try this out and just look at it, it'll give you guidance on, say, how would you adjust the dose, right? What should you do? Should you just avoid the combination entirely, or is it something you can kind of get around by adjusting doses, right? And so that can be very useful if you're in the thick of it and working and need to write a prescription for a patient. You'll get up pretty quickly. Now, rash is a very common side effect you're going to see with this, and this is one that probably has the biggest risk of causing Stevens-Johnson's. So you do want to be really wary with that. Educate patients, hey, if you're seeing new rashes, if you're seeing any kind of like blisters, ulcerations, it could be in the mouth, it could be with mucous membranes, you got to stop taking the drug, come in and get checked out, because with supportive care, it's treatable, right? If not, and they let it go for a while, it can be quite fatal if not treated promptly. But this one's nice because it doesn't have as much sedation. So I do see some adult patients with new onset seizure disorders, they do start them off on lamotrigine, because again, I don't have to worry about them necessarily being say, super sedated at work and things like that. So here's an example of what it would look like if I had an enzyme inducer versus enzyme inhibitor. If I was adding on lamotrigine here, you can see how you would do this. And again, I'm not going to ask you specifically the numbers here on this slide, but to give you an example, if I have an enzyme inducer on board, you notice here that maybe I'm giving more of the drug versus if I have an enzyme inhibitor, I'm giving it, say, maybe every other day to start out with, and then giving it half as often as I would, say, for someone who had an inducer on board. Okay, so give you an example.
When we're writing like prescriptions with like titrating or like changing, how do we go about writing those?
So you could write out each of the steps there. If it's usually a chronic med that they're going to be on for a while, you may just want to go ahead and just give them what instructions they're going to be on at the end, right? So at the very end of it, and then you educate them. Say, hey, so for the first couple of days, I want you to take it like this. It depends on the patient, though, right? So if it seems like they're not really with it enough to handle that, then you may want to have it there on the bottle so they can at least look at that and see that, versus they may be pretty with it and they can handle that. So it just depends on the situation there. Yeah. Up next we have Keppra. This is a super common one that we are seeing used for a lot of pediatric cases. I'm not sure how often for adults because I don't really run into this patient population that often anymore, but Keppra or levetiracetam, like kind of the go-to medication we're seeing here for a lot of pediatric seizures, especially new onset. Yes, sir?
I saw Keppra a lot with adults too.
Okay.
Inpatient, hospital at least.
Yeah, and so it's nice because it's like giving water basically. Out of all the drugs we've listed here, this probably has the least number of side effects or the propensity to cause side effects, which is really handy there. A lot of patients do very, very well on this medication. This one has a pretty novel mechanism here. It's working on the synaptic vesicle protein SV2A, right? And again, it's one of those things where it's just like, it's very specific and very novel, which is why it probably mitigates a lot of those side effects, right? Basically, it's helping to prevent neurotransmitter release, things like glutamate, etc. And so nowadays, even if we're having patients coming in with a new onset seizure, if we maybe hit them off with some benzos at first and they're not responding, this is actually now the second line that we go to, at least for peds. We'll hit them with Keppra, or maybe they were on it at home, maybe they've been non-compliant. We'll go ahead and just hit them with an IV dose here as well to get them back up to steady state, which is good. So, and the doses can range widely. We can give huge doses, and patients really do pretty well on it. One thing that is unique with this one, though, is this increased aggression. This is actually a black box warning they list on there that you can see, especially in the clinical trials with kids more often than not. They got a little bit more aggressive. You know, have I ever really heard about it happening? Not necessarily, but it's one of those things where it's probably a good board style question. You want to know that, hey, of all these medications here, which one's most likely to cause your little toddler to start biting your ankles more or something? Like, it's probably going to be Keppra, right? I'd be very concerned if my child started becoming more aggressive. 3-year-olds don't know how strong they are, and it can get bad pretty quick. Okay, next up we have topiramate or Topamax. This one is also going to be another one you see used for neuropathic pains in some cases there. Has a wide range of activities there, including things like enhancing GABA activity, blocking glutamate channels, mainly AMPA and kainate receptors, block sodium channels, a lot of different things here. This one is renally eliminated, so you do have to watch out for that. Make sure you're adjusting the dose, especially if patients have poor renal functions. You want to be wary of that. This one is not super effective by itself, but it may be used as an add-on agent in some cases there. You know, not so severe from side effect profile, maybe some impaired concentration, but not really as sedating as something like a Phenytoin or valproic acid, something like that. Interestingly, though, in terms of its mechanism, it also has some light carbonic anhydrase inhibiting activity there. So just like we saw the acetazolamide, this will cause a little bit of acidification for the patient there, and will cause a non-GAP metabolic acidosis. I don't know what I mean when I say non-GAP. So you know how you can tell if a patient's in a metabolic acidosis by looking at their Chem7, look for the anion gap, right? And anion gap is measured how? Sodium minus chloride minus their bicarb, right? And so the anion gap, usually 12 plus or minus 4, so I usually say above 16, I consider that to be abnormal. That would consider to be a wide anion gap metabolic acidosis. You guys know the mnemonic for that, for differentials? cat mud piles, right? And so I'm not going to go through the whole thing, but in some cases you can get what they call non-GAP acidosis, right? Basically because the patient's being, oh, do you guys know the cat mud piles?
What's the cat part?
Ah, I can teach you something new. What's this cat business? So basically, starting with the mud piles, so M stands for methanol, which is a toxic alcohol, right? You have U, uremia, D, diabetic ketoacidosis, okay? That's commonly what I see it referred to for. P, I never even see it there. It's called peraldehyde. I've never actually even seen it clinically ever, but they keep it in there because it keeps the mnemonic. I stands for isoniazid, right? Actually, interestingly enough, maybe that's my new term for the semester, but isoniazid has similar actions to those mushrooms I was mentioning before. So call back to the gyrometrin containing mushrooms, and actually is a hydrazine type compound and can lead to seizures. And guess what the treatment for isoniazid induced seizures is? Pyridoxine, right? Just like we saw, we give pyridoxine for patients on isoniazid to prevent what? They have TB, we give it to them to prevent neuropathies, right? Because again, it's affecting the nerve. So again, kind of all goes around full circle, right? So where's that? So we have I, it's isoniazid. We have L, lactic acidosis for sure. E, ethylene glycol, which is kind of similar, kind of cousin to methanol. Okay, and then S, salicylates. Very good. So like aspirin, oil of wintergreen, things like that. Okay, the cat comes into play here. So cat, the C is going to stand for, anyone know? It smells like bitter almonds. If you're genetically predisposed to being able to smell that. Cyanide, yeah, so cyanide's a cat, the C in cat. Alcoholic ketoacidosis is something you can see in some chronic alcoholic patients there. And then the T stands for, anyone know? It's a paint stripper. It's called toluene. Toluene is another one. I actually had one guy who, his big thing, he was a homeless guy, and he would always come into the ER after being found intoxicated at a Walmart. He would go to different Walmarts, go to the hardware section, find paint stripper, and just start huffing it, and then people would find him acting funny in the store, and then call the police, and he'd come to see us. And I mean, this stuff was so nasty after a while that like we eventually he had such bad mental status changes over time. They actually did an MRI at one point. It looked like a moth had been eating out portions of the brain that had such bad damage from it. The guy was like really, really sad case. But toluene is one of those things that can cause a metabolic acidosis. That's cat mud piles. I guess you could do also carbon monoxide for the C as well, so you had 2 C's in there. But and getting back to the topic at hand, topiramate or Topamax will cause a non-GAP acidosis because essentially what you're doing is you're peeing out that bicarb, but you hold on to more chloride. So it ends up balancing out such that you have a patient who's acidotic, because what's a normal bicarb on a Chem7? Like 21 to 28 around there. So I actually had a patient one time when I was on rotations during fellowship, and had a patient who had actually overdosed on topiramate and actually found their bicarb was like 9, which shows they are acidotic, but the chloride was high enough because of that carbonic anhydrase inhibiting effect, such that they had an anti-gap that was normal, right? But the patient was still acidotic, so we still had to give bicarb to that patient in order to correct that. Also can cause kidney stones, so that's another thing to be aware of as well. So little things you see with topiramate, they're kind of unique to it. Okay, next we have lacosamide or Vimpat. This is going to be one that's actually targeting, again, another specific channel type. This is collapsing response mediator protein. Also have a little bit of sodium channel activity, but that's kind of its novel mechanism there. In terms of side effects you might see, they're kind of unique to it. And again, these are some of the newer agents that are now coming out. So again, we don't have as much data on them, and so this is why we don't talk about them as extensively as things like valproic acid or phenytoin, right? But this one you're going to see here can cause some cardiac conduction abnormalities, so you want to be careful if patients have a cardiac history. And it is a controlled substance, so C5, right? So a lot of these newer ones are coming out now are C5s. IV forms are available as well, which is good if you have a patient who's maybe coming in-house and you need to switch them over to something that can't take anything PO. This might be a good option for them. So those are the main agents you're going to see being used. There are other ones that are out there, but again, they're so new and we don't have a ton of data for them. And again, I want to talk about the common ones you're going to see most frequently out there. But getting into it, looking at status epilepticus. We said this is a series of seizures where basically a patient does not leave that post-ictal state before they have the next seizure here. What do we do for these patients, right? So think about them coming into the ER. Airway is always going to be the first thing, right? Because frequently they're going to be not protecting their airway very well. Aspiration is a risk. So if you need to intubate them, you do that, right? So you do the AC first. And then also think about things like, are they a danger to themselves? Do we need to make sure if they're going to vomit, make sure they're rolled onto their side, don't restrain them, remove anything that's dangerous around them, etc. Typically, the pharmacotherapy you're going to start with is always going to be a benzo first, right? So typically lorazepam, if they are out in the field, diazepam rectally is fine, or intranasal, Versed, or midazolam. Those are the common ones you'll see out there. But once I get to the ER, Ativan IV is typically the kind of go-to there because, again, it's more water soluble, so it will last longer to prevent those recurrent seizures, hopefully. Okay. So at that point, what do we do after that? So let's say the Ativan's not working. We've given them 2 or 3 doses. What do we do next? Well, now you come up with your second-line treatment there. Typically, Keppra is a big one we've been moving to nowadays, at least in pediatrics, probably some in adult cases as well. We'll go ahead and do levetiracetam, or in some cases phenobarb, especially for like neonates. We'll typically pull out the phenobarb for those patients there. And at that point, they're still unresponsive. I'm sorry, I've skipped a step here. After the benzos, typically phenytoin is going to be another big one. I jumped to Keppra because in pediatrics we've now kind of made that switch nowadays, but traditionally phenytoin was kind of the go-to after a benzo. Now I may ask you like on a test question, when I say patient coming in, for refractory seizures, what's the first line drug you're going to give them, right? I'm probably not going to get so granular to be like, did you put phenytoin versus Keppra for second line, but definitely got to know benzos are first line, right? Because that's always going to be the first thing you're jumping to. Anyway, so phenytoin, fosphenytoin is preferable for patients, especially if they have like small IVs. And again, if it's a central line, that's no problem. Phenytoin is not going to be bad on the veins there. But if it's a kind of a peripheral line, fosphenytoin is going to be better, easier on the veins. Okay. And then if they're still failing Keppra, they may not be responding to the phenobarb, so we're going to start busting out things like valproic acid, maybe pentobarb might want to pull at that point. There's some other meds as well we've not talked about here. We'll get more into in the surgery section later on. But at that point, that's where kind of general anesthesia comes into play. Just get them comatose as much as possible, support their blood pressure and their breathing, and then hopefully you'll prevent that seizure. Now, there's something called non-convulsive status epilepticus, and I've seen that in some cases too, where basically the patient, and this occurs commonly too, especially if you give them any kind of paralytics. But I remember I had one case where a patient was, she was probably like 79, 80 years old. She'd been on theophylline for a really long period of time, and theophylline's commonly used for what? COPD, right? And she'd been on for a really long time, but no one ever really went back and adjusted based off of her creatinine clearance, right? Because kidneys are going to go as time goes on, and then they ended up, level got too high, she ended up coming in seizing. She was in status epilepticus. And at a point, we were able to get her where she was not convulsing anymore, but she really wasn't kind of responding any way we wanted to, so we actually got a bedside EEG and actually found out she was still seizing, even though her body wasn't moving, right? So it's called non-convulsive status, and so that can happen occasionally. Yes, ma'am.
Are you adding them on, or are you switching?
So you're kind of giving like bolus doses, right? So say for instance, like when they're coming in, I do like say 3 rounds of Ativan, and if that did not work, then I say hit them with a bolus dose, say fosphenytoin, or a bolus dose of Keppra, and see how they respond. Because presumably, if I'm giving a bolus dose, a loading dose, they should be at steady state for a period of time, right? So at that point, say, okay, they should be good. I don't have to worry about giving them repeated doses at that point. So like I said, a lot of our kids, we'll give them Ativan, and if that's not responding, we'll jump to Keppra. That's what a lot of our neurologists are liking nowadays. But it just depends on the provider and what they want to use. So question is, when can you stop? Actually, I don't know if I can do much more here. So we'll stop at the status epilepticus for today. Let me check the board to see if there's any questions. That's a lot of stuff, a lot of drugs, rough on the first day, but it's the nature of the game. Any questions before I let you guys go for the day? If not, I will see you whenever I see you.